Hello, and thank you for joining our live stream. We're here with Jason George DeVries, a foot and ankle surgeon with orthopedics and sports medicine BayCare Clinic in Manitowoc. Hello, doctor. It's always good to see you.
I mean, always good to see you.
Good, good. We'll discuss all you need to know about chronic ankle pain and solutions to easing that pain, particularly a surgical procedure called total ankle replacement surgery. That's also known as total ankle arthroplasty. First, a little bit about Dr. DeVries. He's board certified in foot, ankle, and rear foot surgery by the American Board of Foot and Ankle Surgery. He's also fellowship trained in foot and ankle reconstructive surgery. This live stream is for you, our viewers. So feel free to ask any ankle related questions in the comments section. We'll do our best to answer your questions in real time. Don't fret if we don't get to them because we will follow up once the live stream has concluded. So with that being said, let's just dive right in, Doctor.
Sounds good.
Um, Talk to me a little bit about chronic ankle pain. What is that?
Well, sure. Chronic ankle pain can come in a lot of different forms, and I'll have a lot of people that will come in with various things. Now, with talking about ankle replacement, we're going to talk a lot about arthritis tonight.
Right.
But people that will have other inflammation or deformity, people that have unstable ankles, anything that's really causing pain that is not going away as it should, pain that is causing some limitation of your daily activity, pain that is lingering on more than, say, just a traditional tweak or something along the area, we classify as part of chronic ankle pain.
Okay. And we've talked in the past a lot about the fact that um, your treatment plan doesn't immediately begin with surgery. So what are some non-operative treatments for people suffering from chronic ankle pain?
Well, sure, and that's how we're going to start any conversation with any patient that comes in.
Right,
There'll be simple things. I tell people just activity modifications or lifestyle modifications. People just take it easy. That the simple traditional things: rest and ice, compression, elevation. If you have early onset pain, for more of the chronic pain, like we're going to be talking about today, ankle bracing, maybe needed physical therapy is often a very good treatment option. If that starts getting more severe and people are coming to my office, very often we'll consider
right.
things such as injections, even custom made bracing or orthotics. There's a lot of different treatment options that we would consider. Beyond that, even we may talk about some of the treatments that one of my partners will do with regenerative medicine. So there's a really a much larger range of things that we do non-operatively before we even start talking about surgery. Then once we start getting into the surgical that standpoint, there's a surgical conversation that really is a end of conversation topic that we
Sure,
discuss.
sure. So then what signals to you that a patient, you know, requires a surgical solution to this issue?
Well, very much it is the last resort. So most often people will have gone, especially with chronic ankle pain, they'll have gone through the gamut of non-surgical and conservative measures to try to get better without this. Now, someone that's coming in with an acute ankle fracture or something like that, we may move more quickly into this. But for chronic
Sure.
ankle pain, it is really the option of last resort most often.
Okay. So let's talk a little bit about this procedure that we want to delve in today,
Sure.
total ankle replacement surgery. What is that?
Well, I mean, it is just like the name says. You take out all of the mechanisms, all of the joint surfaces, and do a complete change out. I tell people a lot of times we are literally going to go in and take the bad ankle, remove it, and then install a new one in there. What we're doing is replacing a couple different levels with different pieces of metal and plastic. Another
Okay.
way you can think about it, almost like capping off a cavity. We'll take the joint that'll have two surfaces that are painful, both the top and the bottom, or the tibia and the talus. We'll cap both of those bony surfaces off with a metal component that we expect to grow into the bone, and then in between the two metal components, we'll have a little plastic spacer or a ultra high molecular weight polyethylene spacer to try to allow those areas to articulate and continue to have the range of motion you'd want. And again, try to regenerate or regain the motion that you previously had with your ankle.
Right, right. So, describe for me your average total ankle replacement patient. Is this person an athlete? Are they elderly? Are they on the young side? Is it the arthritis sufferer?
Sure.
Who is your typical total ankle replacement patient?
Well, what I have found, I've been out doing ankle replacements in my private practice now for over 12 years. And, I used to have a very clear canned answer for, here's my normal patient for this. And
Right,
what I found is over time that has changed. Technologies have changed. People's expectations have changed. However, there are still things that we would want to kind of adhere to or make sure we're not leading astray. Not everyone is going to be a
right,
candidate. You do want to make sure you follow the guidelines. So you just kind of run through what is my ideal candidate. I tell people over 55 years old, and there are certainly exceptions that we do younger and older.
sure.
Less than 250 pounds because there's a lot of pressure that goes through your body through a relatively small piece of metal and plastic. So we want to make sure we space that out.
Okay,
And people that are relatively healthy and minimally deformed. Now, again, all of these things are things that are gray zones and can be fudged or pushed. So even in the time that I've been doing this, my indication, my normal patient has really changed. Just to your point that you mentioned athletes, I would not expect to be doing this in someone that's going to be running a triathlon or
right.
high impact sports, but someone that would like to golf or play pickleball or things like
Yeah.
that. Absolutely. So
Okay.
the goal with this is to get people to be back to their level of activity. But again, there is a within reason for some of these.
Okay. So, having heard that, then who's just a clear cut? Nope, you can't have this. This procedure would not be in your best interest.
Sure. So some that come right out are people that have significant medical history. People that have no feeling in their lower extremity or their lower
Okay.
legs
Okay.
are at a pretty high risk to be putting this in. You need to be able to feel where the ankle is in your body to allow it to not push beyond what it can do.
Sure.
Um, I used to say that a younger patient, but again, it's hard to know in certain situations where this would be. I do have a pretty hard line, family, with people that are actively smoking. There is some risk
Okay.
associated. This is a big operation. This is
Right.
something that we do want to make sure we give the patient every opportunity to heal as well as possible. And there are some early risk factors where we want to do that. Um, Age and weight are relative indications. So, like I said, over 250 and less than
Right.
55, we would have to have a relatively lengthy conversation with the patient and look at what our risks and what our benefits are here.
Okay.
And there are certain levels of deformity that
Sure.
if we cannot straighten the ankle out,
Sure.
you can't have one that's going to be put in crooked or is not going to have a stable foot underneath it. So
Right.
there are extremes of this. Now, again, we can certainly correct some deformity, but there are extremes that simply are not replaceable.
Sure. All right. Thank you.
Yeah.
If you're just joining us, we're here with Jason George DeVries, a foot and ankle surgeon with orthopedics and sports medicine BayCare Clinic in Manitowoc. Please go ahead and ask any ankle-related questions in the comment section. We'll do our best to answer your questions in real time. So let's continue with our conversation. When an ankle condition is diagnosed and surgery is found to be the best treatment, how do you then determine the ideal surgical treatment option? I know, for example, there's a procedure called ankle fusion. How do you determine ankle fusion versus what we're talking about today, total ankle replacement?
Well, just like treatment overall, there are more and less conservative measures, and you really want to make sure that the treatment that you offer for the patient is the least invasive, the least destructive. So chronic ankle pain may be a result of just being unstable. Some of the ways we determine that are with X-rays. Plain film X-rays are always going to be done early on, and they'll give us a good, clear idea on what is the level of cartilage or the smooth gliding surface that is available.
Sure.
Advanced imaging, such as CTs or MRIs, will look at some of the soft tissues and some of the other structures. Someone may simply do well with an ankle arthroscopy, or where a camera is stuck into the ankle. We can clean out some spurs or small little loose bodies or something like that.
Yeah.
When we talk about ankle fusion and ankle replacement, these are what I would call end stage or joint destructive options. These are when the joint is no longer something that we can fix and restore back to your normal ankle.
Right.
Instead, we need to find something. Ankle fusion is where the bones of the ankle are screwed together. So, like we done with plates or screws or something to get the two bones to grow together. Now, that is still a procedure that is excellent. I still do a lot of them in certain conditions, but it will restrict the motion that people have. So, if you kind of
Yeah.
on your own body, look at how much your ankle moves and how much you use it in walking. There will be some changes in how you walk and stuff like that. An ankle replacement will be something that will allow for more natural motion, will allow to de-stress the joints around it. If there's other joints that are already somewhat problematic, you may want to make sure we maintain that.
Right.
But again, what we're looking at is what is the least destructive that we can do to give the patient the outcome that they're looking for.
Okay. Okay. So let's talk a little bit about what happens during ankle replacement surgery. Now, I know you could teach a class on this over the course of several weeks, but for our interest tonight,
Sure.
just give us the total ankle replacement for dummies version of what happens during this surgical procedure.
Sure. This is something that I will always do in a hospital. This is not something that can be done in the office or anything like that. While we do have different approaches or incisions, this is always done with an incision, either along the front, which is what I do, or along the side of the ankle.
Okay.
That allows us to get to your ankle joint. Just like I said, though, after that, you have certain guides and different um, structures and jigs that will allow us to physically cut out the bad joint, remove
Sure.
it, and then install two pieces of metal and plastic in between there to replace the area. After that, you'll have a splint put on. I'm about 50-50. Some people will stay overnight. A lot of these I do as an outpatient now as well. So you come
Really?
into the hospital, you have the
Okay.
procedure performed. A couple hours later, you go back home and recover from there.
Okay. Okay. Yeah, and that was a question I had for you. So a hospital stay is not necessarily required.
It is not necessarily required, and that again, that's changed in the time that I've been here.
Yeah.
While not all patients will be Medicare insured patients, Medicare is a large insurer of America here, so they set out guidelines. And when I first started out, this was approved only as a inpatient procedure, which means you had to stay overnight. That was the only
Sure.
way that it would get approved. And several years ago, this actually changed where it's no longer approved as an inpatient at all. So it has to be done as an outpatient procedure. So
Okay.
things do change. Technology has changed. This has gotten a lot better in the time that I've been out there. So again, you always like to ask me typical patients. I would say
Yeah.
typically these are done as an outpatient at this point.
Okay. Okay. So I get this procedure. I'm I'm at home recovering.
Mhm.
What's the downtime?
I break this up into months. When I tell people it's about a 4 month recovery. The first month
Okay.
will have you protected, either minimally walking on it or not walking on it at all. The next 1 month, you'll be walking on it, so you'll be up and around. You'll have a boot
Sure.
that you can take off. At that point, you can shower, you can move things around, you can take it off to sleep. There's a lot of freedoms that will give you at that second month.
Sure.
That's what I call the rest period. That's the time where we really are careful. We're very protective of the area. We want to make sure things have healed. You'll see me a lot during that time. We'll have more visits during those first 2 months. And then the second 2 months is what we call the rehab period. So at this point, we are comfortable that you're walking on it, you're feeling more comfortable. But the reality is, we just had you locked away in a boot or a splint for 2 months. So
Yeah.
there's a rehab. We got to kind of train you to give your life back with your new ankle. And that's where we'll get into things like ankle braces, a simple ankle brace like you'd see a basketball player wearing. Um, and getting into physical therapy.
Mhm.
We'll always involve physical therapy. We want, again, We want to maximize what you're able to do with this. We want to make sure that we get as much range of motion, get the swelling out, get the
Sure.
pain out, make sure the scars are mobilized. So as far as downtime, 1 month where it's pretty restrictive. 4 months is pretty much a full recovery from both the rest to the rehab period.
Wow. Okay. Great. So, once you give the all clear,
Hmm?
are there any restrictions? You know, if I enjoy Saturday hoops, going out to the Y or whatever, um, can I resume that? Can I resume cycling? Like, are there any restrictions once I get the all clear on this totally, replaced knee, ankle?
Yeah. Um, there are better decisions that you can make with your time. So again, we don't. These things have a lifespan on them. So
Sure.
unlike your ankle that is supposed to regenerate and supposed to rebuild, metal and plastic does not. So there is a lifespan. Now we know that at least 90% of them last at least 10 years. We just don't know beyond that.
Yeah.
But the mileage and the pressure you put on to it during that time is going to determine how well this does. So I do want people to be active, but low impact and no impact. What I tell people is walking, biking, a stationary bike, absolutely. My ideal sport for this is golf, because this what
Sure.
it shows people is I do want you out. I want you outside. I want you on uneven ground. I want you twisting and moving, and I want to make sure you can have a good natural motion across the area. You can even walk the course. That's fine.
Right.
We're avoiding some of the, again, I mentioned before, like a triathlete. You
Yeah.
want to run hurdles. If you wanted to play football and get tackled. I mean, there's some risks that are probably an unreasonable amount of risk to ask
Sure.
on an artificial joint.
Sure.
Um, that being said, I do have patients that once they have it done, they are feeling good. They are back to jobs that are putting some pressure on it,
Good for
going up
them.
and down
Yeah.
ladders, getting back into some activity because they can now get back into their exercise and lose weight. And we have that conversation again.
Yeah.
What is the risk, the benefit, the pros and the cons? What do we expect out of this thing? And what do we want to do? Because again, each of these conversations is individual to the patient.
Right. Okay. Good. Thank you. For those watching, please feel free to join me in asking any ankle-related questions. Post yours in the comments section. We'll do our best to answer you in real time. If we do run out of time, just watch for a response after our live broadcast ends. So we have some images that will be coming up shortly.
Sure.
And while visually they're quite striking for somebody such as myself who is not in the know as you are, I mean, I'm not 100% sure what I'm looking at.
Sure.
Maybe you can tell me what we're looking at as these images kind of scroll by.
Sure. Well, these first two images are looking at what we call a lower profile ankle. So the white components in there represents the metal. So you'll see a couple screws
Yeah.
that are there, but these wide white plates. These are, like I said, kind of what we talked about the end caps to the arthritic bones. We remove
Right.
that arthritic irritated area and cap it with this metal piece over top. What you can't see on here is the plastic spacer. So when you'll see these two white metal plates that are sitting apart from each other. They're not floating in space freely. Instead, what they do have is a little plastic spacer in between. The remaining part is your normal bone. So again, what we're trying to do with this, we try to preserve the amount of your anatomy, your bone that we can. With this example here, it just kind of shows you that there's not a one size fits all with these.
Yeah, I see that.
From a much smaller piece to something that's a lot more metal. So again, that the
Yeah.
white that you see there is metal, and that is something that continues to evolve on. Well, how much of the patient's bone needs to be removed? How much can we leave in there? This allows us to have some different options for different needs and different perspectives. This gives us some options for revisions. And again, we talked before, even with ankle replacement. So once you've decided this is go, we do try to be the most conservative that we can. I tell people to burn the fewest bridges that we can to try to do the least invasive things that we can. Even when we're talking about replacing the total ankle, there are levels and there are different amounts that we can do to a patient, understanding that we need to address all of their issues, but always think about, well, what are the other options that we have and what's going to be the best case so that this patient can have a long lasting well-functioning ankle to get them back to doing all the activity and the things that they'd like to do.
Yeah. So remind me again, these replacement parts, are
Yeah.
they're a mix of metal and plastic? I
Yep.
mean, okay, okay. And
So
then,
the metals will be different alloys, and different companies
right,
will do different ones, and then the plastics in between will be different combinations based on companies and research. And again, these things change continually, trying to give people the longest lasting options that they can have.
yeah. So looking at these images, I
Yeah.
mean, they're rather striking to me. I'm not accustomed to, this is your world, right? So
Yeah.
um, it looks involved. So how long would a surgery like this take? I mean,
Sure.
how long is my ankle going to be up on the table?
Yeah, I tell people that I usually will plan for 2 hours for an ankle replacement. Now, it does not take that long in
Okay,
the vast majority of patients. But what I always want to think is we want to make sure that we are focusing only on the patient, that we don't want to be rushed by anything else. We want to make
right.
sure that there's nothing else going on there. I would say the majority of these are done in around 1 hour.
Okay,
It'll always be with myself, and I will have a team around me
sure,
that is skilled and educated in this as well. So it is involved. I mean, to your point, this is something that is involved, but we try to optimize it as much as possible. We want to
sure,
make sure that we are surrounded with people that are highly competent, have done a lot. There's a lot of repetition. We want to make sure that the team is prepared, whatever aspect of the team that is. And when that's done, when you can do this on a scale where it's done frequently, you can find that things will get efficient, which
sure.
is better for the patient. There's less time, or as you said, your ankle is there on
Right.
the table, open up. There's less time under anesthesia, so doing it in an efficient way is very beneficial for patients and for the longevity of this.
Okay. We do have a question that came in, so I'm going to throw this your way.
Yeah.
Um, in your years of doing this surgery, how many ankles approximately did you have to fix because the patient wore out the replacement? This is to
Sure.
your point. You kind of talked about that a little bit before. So,
Yeah. We talked before. I'm actually giving a talk coming up in Los Angeles about this. So I only recently had to really dive pretty deep in the ones that I've had. So
yeah.
um, I do between 10 to 20 a year. I've done that. So it's 200 to 300 that I've done. Um, I've had less than 10 revisions where
Okay.
people had to have it taken out because it wore out. I've had one infection that was an unfortunate result of a wound issue. So it does happen, and again, that's why you want to make sure that people are aware. I've had a couple of people that come in that have had ankle replacements done elsewhere. I've had a couple of revisions of those as well. Because this is not a hugely commonplace procedure as of yet, it's getting to be more and more so. But there's not a lot that are done outside of people that are not doing this routinely, but it is becoming more common. It is becoming more accepted. So having the ability to revise or change someone back is important. You need to know how to do it, and that's
Yeah.
actually the talk that I have coming is looking at how to deal with an infected ankle replacement, which thankfully is not a common problem,
Right.
but it's something that you need to be an expert at because it is a reality that does happen.
Okay. So, do your patients experience swelling, drainage, or pain after surgery? And if so, how do you monitor that? And like, what do you do to address that?
Well, we can talk ahead of time, make sure people are educated. You talked about pain, drainage, and swelling. Pain, yes, absolutely. And the motto that I use is to plan for the worst and hope for the best. So we'll discuss with
Sure.
people ahead of time different techniques, either through medication, elevation, narcotic pain relief, activities to avoid during the time. Swelling, absolutely. And again, that's one of the things we plan on, which is why I tell people it's not a 1 month or 2 month recovery, it's a 4 month
Sure.
recovery because at
Sure.
2 months, we're pretty happy with it. It's going well, but the swelling, the irritation, the lack of mobility is where the rehab phase comes in. Drainage, we would hope to avoid. In fact, I take some extra steps early on for the first week where we'll have a specialized device on the front of the ankle to remove any excess fluid or swelling out of the area.
Okay.
That is something we'd like to avoid. But those first couple of months is why I keep such a close eye. That's why you'll end up
Right.
seeing me post-operatively. We'll see each other at the clinic
Right.
to look for drainage. And if something does happen, we can head it off before it becomes a major issue.
Right. Good to know. Good to know. So you talked very briefly about rehab. So is that required rehabilitation or physical therapy services? Is that required after a procedure such as this, or is that case by case?
I tell people it is required. No,
Okay.
I'm not going to be naive enough to say that some people just refuse, but that is part of the early on education, the planning, the expectations that we would have. Because again, we know full well that this area will have some swelling, some stiffness,
Yeah.
and in order to have the best long term outcome, I do recommend 100% of my patients go to physical therapy, go to rehab. We have protocols built for ankle replacements. So if people need to do this closer to home, or
Sure.
sometimes help people that travel for the winter, we can send a protocol to where you have it done, because it is something that is, I believe, integral to the success of this procedure.
Okay. So if I've had this surgery with you, this
Mhm.
procedure, and
Yep.
I've followed your instructions right down to the very
I
last
would
minute,
expect nothing less, Tommy.
I've done rehab, everything. How long should my replacement last then? On average, would you say?
Sure. Um, we expect this to last for your life. Uh, the reality is, they don't all.
Sure.
So, like I said before, about 90% lasts at least 10 years. And then we don't have the longer term data that
Okay.
says, 80% will last 20 years and 70% will last 30 years. We simply don't have that.
Okay.
But when we put one in, the reason we do these guidelines is because we expect it to stay in there, to function for you, and to work for you and give you the relief that you need. And we optimize things as needed. Um, and then we deal with the fact that they don't all last,
Right.
and then address those as needed with whatever needs to be done.
Okay. Good. Good. Well, thank you for that information.
Yeah.
If you're just joining us, welcome. We're here with George DeVries, foot and ankle surgeon with orthopedics and sports medicine BayCare Clinic in Manitowoc. We're hosting this Q&A session on total ankle replacement surgery. So we'll just keep the conversation rolling.
Sounds good.
So how do I know whether my ankle issue, my ankle pain, the aggravation in my ankle, how do I know whether or not that rises to the level of me seeking out somebody such as yourself for assistance?
Sure. We've talked a lot about getting people back and being active. What the number one thing I tell people is, if it affects your daily life. Now, that will be different for every single person, right? So a 20-year-old's daily life may be affected because they can't run the distance that they're looking for. Someone into their seventh and eighth decades may want to walk the dog, or play with the grandkids. So
Sure.
whatever activity you're looking for, when you either can't do it or can't enjoy it because your ankle or your foot is stopping that or impeding that, that's when I would get checked out.
Okay.
And again, that may be early on in the process and something simple can be done. That may be later on, and just your pain tolerance is a little bit higher. But I tell people, the biggest thing is, we want to get you active. We want to keep you as active as you
Right.
want to be. As long as you're able to do that, um, I'm comfortable with that. Once it affects your life, your activities, you can't do the things you want, I would absolutely get that checked out.
Okay. So I'm going to throw a scenario at you.
Yeah.
So say I've been advised that, yes, this is a procedure I need, total ankle replacement surgery. I'm connected with you now, right? What are some questions um, that you would suggest I would be asking someone such as yourself, the surgeon who's going to do my procedure? What
Sure.
questions should I be asking that person?
Well, I think it probably falls in a couple different categories. One set of questions is, this is a big operation. Are you comfortable with the surgeon that is performing it? Because those are reasonable questions. I get asked those: how many times do I do this? How often have I been doing it?
Yeah,
How long? Things like board certification should be something you want to make sure that they are board certified to do this. There's a lot of different ankles out there. How many do they use? How do they pick which one that they would use? How long have they been doing ankle replacement, and what is their experience? Like the question we had before, in dealing with some of the complexities.
Right.
Is there a common location you do, and do you have a consistent team? Because again, what you want to do is you want to make sure you optimize. You're comfortable with your surgeon. They have the appropriate credentials, which I assume if they're doing it, they do.
Sure.
But this is still not a tremendously performed procedure. I would advise people to find someone that they're comfortable with, and someone that has the knowledge and the background to do it. The second set of questions is the logistics, all the stuff that we've covered here.
Right.
How long will it last? Do I go to the hospital? What can I expect to do? And again, that's really where it's going to come in, where I'm going to be very upfront with people. Like, what are you hoping to get out of this? If they say, well, I'd like to be, I'm 35 years old and I work in a foundry, I'd like to be able to work 60 hours a week at the factory. I said, well,
Right.
this may be something that we should either wait or address. Um, do they want to get back to golf, and what are the expectations afterward? Because again, we want to make sure the more clear-eyed people are, uh,
Right.
the better they're going to do, because they're going to understand what is expected from them, from me, but also what they can expect afterward.
Okay. Can you offer up some tips on how people with ankle issues or a predisposition, I should say, to ankle issues, how can they keep their ankles healthy and avoid seeing you?
Yeah, yeah. Um, your body is an amazing thing, and it will let you know if things are going wrong. So if you are doing things, you're getting repetitively irritated or injured or swollen along the area,
Right.
that is your body letting you know that this is more than just something you should maybe muscle through. Um, if you are finding that you're consistently rolling it or spraining
Yeah.
it or something like that, you may do well to wear an ankle brace if your
Right.
internal support system is not doing it,
Right.
allowing that. Making sure things are moving along. Sometimes when people have pain, they stop moving their ankle, and you can end up getting a very stiff ankle, which can be not a great option in the long run.
Okay. Okay. A couple more questions for you. So if patients are dealing with symptoms they think might be related to any of the things that we've talked about today, um, what should their course of action be?
Well, I mean, obviously they'll be watching information like this. So early on, I really don't have a lot of problems with internet searches or googling the problem. I think that's an important part of every patient trying to educate themselves, and
Right.
they should do that. So
Right.
um, finding out, what do their symptoms lead to, and try to find some early on treatment remedies to, again, avoid seeing me. However, once it gets to the point where it is starting to bother you, you make a call. What we'll do is we'll say hi. We'll figure out what the reason for the visit is, what the limitations are. X-rays will be usually done very early on as well, because that will give us an idea. At what stage are we catching this problem? Is this something
Right.
that we're catching it early on? Or are we catching this later on? I think that's probably where I'd have patients start. A little bit of early on education, listen to their bodies, and then preliminary evaluation with someone who does foot and ankle would be very helpful.
Okay. For somebody trying to reach out to you,
Mhm.
is the process at all complicated or hindered by having to get a referral or anything like that?
Typically not. Now, some insurances may be different, but
Hmm.
typically this is something that patients can call. We're happy to see all patients. We accept a very wide variety of insurance plans, so it is
Okay.
not usually difficult to see me. Now, again, each insurance plan may be somewhat different. I can't speak on all of them, but I
Yeah.
certainly do not require a referral.
Okay. So we've talked a lot today. We've learned a lot today. Is there anything that we kind of haven't touched on that you want to just kind of add before we bid you adieu?
Sure. I guess when people are looking around, I guess I would try to always focus on someone that has an interest in this. This is part of the continual care of foot and ankle practices. This is a particular interest of mine. I mentioned before I'll be going out to LA in a little while to give a talk on this. This is something that I do routine research. In fact, me and one of our partners here at BayCare Clinic are actually going through the process to establish a research protocol to evaluate our outcomes so we can give people some real data.
Wow.
This is something that I think is a big deal, and to try to find someone that not only can do it and is qualified to do it, but is passionate to do it as well would be a benefit for patients.
Okay, great. Thank you so much. Well said.
Absolutely.
We thank you for your time and for sharing your expertise. Really appreciate it.
I mean, always a great time.
Thank you. And we thank you, viewers, for joining us. If you have additional questions for Dr. DeVries, please ask them in the comments section. We'll continue to answer them online. To learn more or to request an appointment, please visit baycare.net/ortho. Thank you so much for joining us, and enjoy the rest of your day.
Have a great night.